Okay, thank you very much, Chair, and also thank you very much for everybody and to come to the symposium. My name is Masaki Inaba. I'm working as the Executive Director of the Global Call to Action Against Poverty Japan. And I have been working on HIV/AIDS from 1994, and firstly in Japan, and also after 2002, I changed my work for the African HIV/AIDS issues and also the advocacy for Japanese ODA and health policy. So I speak about universal health coverage, or UHC, but I'm a little hesitant on it. It is because there are somewhat unhappy relations between HIV/AIDS and UHC. In civil society working on HIV/AIDS, there are a kind of atmosphere against UHC, like that UHC and HIV/AIDS are competitive on post-2015 development agenda. And there is a strong notion that UHC should not be set as a goal because it is only a tool to achieve higher outcome targets. My opinion is different. UHC and HIV/AIDS can be and should be complementary each other. A horizontal approach for health, including universal health coverage, is essentially complementary with disease-specific approach. If universal health coverage is defined and implemented well, it will support ending AIDS. Now, we, civil society working on HIV/AIDS, need to create concrete position on universal health coverage and strengthen our advocacy for universal health coverage. At the same time, we have to be cautious about bad UHC, which degrades its concept of universal human rights and equality and set a ceiling following short-term financial sustainability. First, see the progress of policy creation process of UHC. It was first defined by WHO in its World Health Report 2010, ensuring needed health services for everyone in the world without incurring financial hardship. In this year, 2014, WHO said that two necessary components: entire population should be benefited, one, full spectrum of good quality essential health services according to need, and second, protection from financial hardship due to out-of-pocket payments for health services. Basically, UHC is based on universal health rights, human security, and equality. How is the relation between universal health coverage and the social determinants of health? It is at least complementary each other, and if social determinants of health is integrated to UHC, it could be more comprehensive. Next, see the political map around UHC. This concept has been pushed by WHO and World Bank Group. These two organizations have made strong efforts to sophisticate its definition to set it as a major target in health goal of post-2015. As for donor countries, France and Japan have been continuously supporting universal health coverage. France, with Germany, has a history to support establishing social health schemes in developing countries. Implementing countries, there are more and more middle-income and low-income countries that have established some kind of the financial risk protection schemes, including health insurances or tax-based mechanism. As for NGOs and private foundations, many NGOs, including Save the Children and Management Sciences for Health, support UHC. On private foundations, Rockefeller support UHC. Oxfam supports equity-based UHC that abolish financial barriers, including out-of-pocket payments. So, how is the relationship between UHC and HIV/AIDS? UHC is universal and target entire population. Essentially, it should include key affected populations, including men have sex with men, sex workers, people who using drugs, migrants and prisoners, without any barriers. It is non-negotiable. It shouldn't and can't limit its coverage only for civil servants and formal sector workers if they name it universal health coverage. It should provide good quality essential health services to make a difference in its outcomes. It should include sustainable and continuous access to antiretroviral therapy and also CD4 and viral load tests and opportunistic infection treatment. It should include scientifically effective means of prevention, including harm reduction, PMTCT, etc. It should support community-based care. Also, UHC means financial risk protection from out-of-pocket payment. It should ensure free or affordable access to antiretroviral therapy and medicines for other opportunistic infections for all. There are some important issues that are not included directly in UHC, such as eradication of social, cultural, and legal exclusion and discrimination, and extended community system strengthening. But a good UHC framework can and should support our efforts to fight HIV/AIDS. So we need to advocate for UHC framework, especially for post-2015 era. There are several urgent necessities. First, transformation of financial resources for health and HIV/AIDS in middle-income countries. There is an emerging transformation from aid-based development to domestic resource mobilization. In these countries, resources for health, including HIV/AIDS, has been transforming from disease-specific budget by external resources to universal health coverage-based fund from internal resources, especially in middle-income countries, in Asia Pacific, and Latin America, and also Middle East and North Africa. In these countries, it will become necessary to finance HIV/AIDS from UHC channels. So we should set universal health coverage universally, including key affected populations, and set effective coverage, including universal access to HIV/AIDS treatment, prevention, and care. Secondly, we came to know that non-communicable diseases, or NCDs, have become a major threat for people living with HIV/AIDS. Adding to the problem of co-infection of HIV-TB or HIV hepatitis C, NCDs, including side effects of decades-long treatment of antiretrovirus, like diabetes and osteoporosis, have been one of the major threats of people living with HIV/AIDS. Main financial sources of NCDs, both prevention and treatment, are UHC-related channels. Thirdly, there is several bad UHC concepts which degrade the original idealism of UHC. And also, we have to consider that there is an original fault in the concept of UHC. There are two types of UHC. We can name them as good UHC and bad UHC. Essentially, good UHC inherits the idealism of health for all of Alma-Ata Declaration. It is a realization of health for all from the visions of equity, finance, sustainability, and resilience. But if it is designed through narrow views of short-term financial sustainability, the idealism will be thrown away. In such bad UHC, its financial sources will be from national health insurance based on insurance expenses paid by people who need medical care, and the financial ceiling will be set by the name of financial sustainability. When it is set, services will be limited following the sustainability, and high-cost health services, including antiretroviral therapy, will be excluded. And the eligibility will be also narrowed down. It will cover only civil servants and formal sector workers, and key affected populations will be excluded. So that bad UHC is most likely scenarios in certain numbers of middle-income and low-income countries. If universal human rights, equality, and effective quality health services coverage are thrown away, it is no more universal health coverage. Adding to that, there is an original force in designing UHC. When UHC is designed, it focuses mainly on economic inequality, not considering cultural and barriers, cultural and social barriers well. It's sometimes lacking the vision of eradicate social exclusion, and sometimes it and lacks sufficient consideration of the diversity of the people who need health care. Actually, it ignores the existence of key affected population of HIV/AIDS. We can't lose our position we have developed through AIDS activism since the early stage of the history of HIV/AIDS. So finally, conclusion. UHC is essentially based on universal health rights, universal human rights, human security and equality. UHC and HIV/AIDS are at least complementary each other. We should create concrete position on UHC and HIV/AIDS. It is because UHC were more influential in global health policy in post-2015 era. Considering non-communicable diseases among people living with HIV/AIDS, civil society working on HIV/AIDS should strengthen advocacy effort for UHC. UHC should be universal and equity-based for everyone, including key affected populations and informal sector workers. UHC should ensure universal access to HIV prevention, treatment, and care. We have to be cautious about bad UHC based on short-term financial sustainability. Thank you very much.